Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing another really great guest involved in creating a better tomorrow for millions of people out there. Today, we have the honor of being joined by Dr. David Feinberg, who's chairman of Oracle Health, where he and his team are committed to ultimately making healthcare more accessible, affordable, and equitable, building these open healthcare platforms with intelligent tools for data-driven, human-centric healthcare experiences to connect consumers, healthcare providers, as well as payers and public health and life science companies. Previously, Dr. Feinberg served as both the president and CEO of Cerner, which was acquired, now part of Oracle Health, again, leading the development of these tools and technologies to, as they say, improve both the patient and caregiver experience. Dr. Feinberg was really trained as a pediatric psychiatrist. He built his early career around helping children and families. He served as both the president and CEO of UCLA Health, as well as Geisinger Health, prior to assuming a major leadership role at Google Health in 2019. He began his career at UCLA researching and publishing in various areas of both addiction and attention deficit hyperactivity disorder, took on additional leadership responsibility, including becoming the medical director of the Resnick Neuropsychiatric Hospital. He earned his medical degree from Chicago Medical School, and then also holds an economics degree from UC Berkeley, as well as an MBA from Pepperdine. A lot to get into today. A lot of really cool topics. We're honored to have him. Dr. David Feinberg, thank you so much for taking time to come on the show.
So excited to be here with you and your audience.
Yeah, it's great having you. I would love to start off at the beginning. As mentioned, you originally trained in pediatric psychiatry, and I took a look into some of your publication record back in the day, and as it said in the bio, everything from ADHD to pediatric schizophrenia, opioid misuse, interesting study on mass hysteria in school children. David, tell us a little bit about your background and what got you focused in the area, specifically pediatric psychiatry, if you would.
Well, you certainly did your homework, so I haven't heard about those studies in a long, long time. What got me interested was, I think as a little kid, I always wanted to be a doctor. I don't know why. It wasn't like I was sick or there were doctors in my family. So I thought I'd do pediatrics. And then in med school, I did a lot of rotations around pediatrics in preparation for that. And one of them happened to be child psychiatry. And I just fell in love with it. It was the only one that at the end of the rotation, I had more questions than answers. And so decided to go into child psychiatry and adolescent and addiction. And it was a perfect fit because it was just an amazing privilege to work with patients and their families, hopefully change the trajectory in their life a little bit so that long-term they'd have better outcomes. So I really look back at my clinical experience as the best job I've ever had.
And, I noticed that around 2000, in addition to, all the obviously clinical work you're publishing, you start publishing more on sort of this, interesting nexus of patient, prescriber, payer intersection and a wide range of issues. Some of these topics included, managed care formulary structure, contracting issues. You had a really cool paper on, what was happening in direct-to-consumer advertising at the time entitled Daddy, What's Erectile Dysfunction? So a lot of various themes. Talk a little bit about this time and some of what you were just experiencing as a pediatric psychiatrist in this evolving healthcare era, let's just say, that was happening at the turn of the millennia there.
Yeah, so that interest in, I guess you would call the business of medicine, really came from my what I learned from my patients. So there were a couple patients early on that really, I think, I'm still trying to do right by. One was a little boy who was 12 years old and came in with the first psychotic break. His dad was a used car salesman from Vegas. Mom had left the family. I was at UCLA at the time. And it's about 31 years ago. I know this because our daughter's 32 and she was a baby. And I thought I was super smart. And I was telling him about all kinds of things like nucleus accumbens and ventricles and anticholinergic. And this used car salesman looked at me and said, Doc, do I need to build a room out back? And my eyes teared up and I thought, holy moly, like this guy's life trajectory just changed. I need to talk to what would have happened if that was my kid? And I need to talk to patients in a way they understand. So that kind of concept of understandability, get away from the white coat and just be a real person with other people that are going through hard times became kind of foundational for me. And then another one, a couple of years later, is a little girl writes in her haiku poem, she's 8 years old, that she wants to tie yarn around her neck and kill herself. And I'm like, wow, she got to see me because they knew someone in LA. And so they got in 3 weeks. And I thought, well, what if they didn't know someone? Does that mean she never gets in? And how come anyone who has a kid who's in third grade, who has thoughts of hurting themselves, isn't getting in today? And that's where I kind of became obsessed with like same day access. Now, I didn't know these terms, but I was like, people need to get in. Healthcare needs to be understandable. We got to focus on the big things. And those things then got me thinking a lot about the business of medicine. And it was an interesting time because if you go back then, there was a lot of healthcare reform talk with Bill and Hillary Clinton. And Los Angeles was a hotbed, and it seemed to be like the two things that the primary care gatekeeper couldn't figure out was dermatology and mental health. And so I was like at this nexus where at UCLA, I started knowing more than my senior colleagues because I got into this, like, how do we get people in and what's the payment and how do we make it understandable? So it was really that patient stuff that got me interested in the business of medicine. And then I think I was lucky that it was at the right time. Then I went back to business school and a lot of doors opened up.
Yeah. No, it's fascinating. Again, you're connecting obviously the clinical care, as you're saying, the business of medicine, but then there's sort of one other angle here that's kind of important, being at a major academic health center, which have these responsibilities. Look, we have to train the next generation. We have to obviously take care of patients. And at the same time, we have to do research. We have a lot of responsibilities here. And in comes, the theme of big data, of digital tools into, some of the work you're doing. Two articles that you published in JAMA, one in 2013 on academic health centers and the evolution of the healthcare system. Again, talking about, hey, we need these solutions, or else, the very fragmented, as cool as what we're doing at the health center, it's still extremely fragmented. We're duplicative care and claim processing and all that stuff. We got to have the proper solutions. And then a couple of years later, another JAM article, More Value for Payment Reform and Healthcare and Biomedical Innovation. You talk about, hey, as we have these new innovations that are coming along, we need to make sure we're using them properly. We can't use them on everybody. Again, big data, digital tools allow us to properly triage that. Take a little time and talk about these papers, if you would.
Well, I had the opportunity after working at psychiatry at UCLA to lead the UCLA health system. And leading the UCLA health system to me was it's basically three missions that you talked about, like train the future workforce, come up with the discoveries, and take care of patients. And actually, if you think of academic medical centers in those three ways, they're not actually the best in any of those. Like you probably get more value from a school, a DO school, as far as training doctors. It costs less money and they get more out. Some of these clinical research organizations can do studies faster and better than an academic medical center. And clinical care oftentimes is great and complex at an academic medical center, but they can't get you in for 6 months, or it's not, the communication coordination is not good. So for academic medical centers to exist, these three things have to be synergistic. It's got to be better than the pieces. So that was this kind of concept of how do we make this better. I'm really pleased with the team at UCLA. We took patient satisfaction from the 28th percentile to the 99th percentile, which rated us the highest of any hospital in the United States, academic or not, on basically would you refer us to a friend. And that focus on taking care of that patient also then meant we were training people the right way around patient-centered care. And our NIH grants went up because we had, a lot of folks coming through the system that were willing to participate in trials of oncology, et cetera. So, UCLA discovered the PET scan, diagnosed the first case of AIDS, came up with Herceptin, like amazing discoveries, but it doesn't matter if you can't get in. So it was really then pulling all that together. And as you say, Ira, when you pull that together, a lot of it, besides the change management, is the data and really understanding, where these interventions are working or not working, whether that's actually in the research side, the education side, or the clinical side. So really focused on, how can we become a learning organization to be better in this kind of tripartite mission. I don't know if that's a word. I think it is.
No, it's a cool word too.
It's a cool word anyway.
Awesome. So in laying that groundwork, and we'll get to Oracle in a teeny bit, I just thought one other interesting place to go, again, in this concept of putting the big data to work, would be a couple examples out of both Geisinger and your time at Google. Again, we see examples here of big data for treatment, for prevention and diagnosis. At Geisinger, a really interesting set of work that you were doing with Regeneron and Partner Healthcare, looking at the BRCA1 and 2 mutations, obviously, as we're on this cusp of personalized precision medicine, deciding what patients X drug will work and what not. Big data for diagnosis at Google. You worked on this UK National Health Service program to identify properly acute kidney injury, and then obviously the COVID information, sort of vaccine access, symptom management page that you guys developed, a nice case in prevention. And again, these are all three cool examples, whether you want to touch on all three, whether the other cooler ones that you want to mention, but I thought these were a couple really interesting proxies of how you started to translate big data for these important needs.
Yeah, those are great ones. So at Geisinger, we had the MyCode program, which was the largest program of whole exome sequencing with return of results. So UK Biobank had more genomic information, but they didn't tell you that they were BRCA positive, at least at the time I was there. And so when I was at Geisinger. So this was a real opportunity to take a population that is remarkably stable in northeastern Pennsylvania. People don't move. And Geisinger was innovative, not to be innovative, but because they really loved their community. And so that's why they started an insurance plan, because they needed affordable health care. We really scaled up the whole exome population health program. And my wife, who thankfully follows me to all these places, is a pulmonary critical care doc, but started a fresh food pharmacy there that provided food to diabetics that are food insecure and their families. And we saw it was, again, using data, drove down healthcare costs dramatically and was 2.5 times better than metformin if you eat kale and quinoa. So it was this concept of the population and what could be right for them. So of course that included kind of this precision medicine, but also low tech, making sure they had food available. Geisinger was, I would say still is, incredibly data rich, being a stable population, having the claims data because it's the insurance side, the first outpatient install of Epic ever. So long history of electronic health record. And then we have the genetic data on top of it, and that's actually how I got to know the Google folks, but it becomes a very data rich sense. Think of it as kind of like Iceland of America. And then if you want to use that data and innovate, wow, you can do some pretty cool stuff. That's really the Geisinger story, which was phenomenal. The question is then, how do you scale it? And there's always been questions about how do you take Kaiser and scale it? And now Kaiser actually owns Geisinger. But how do you take these models that work and scale? And I had the opportunity to go to Google to lead Google Health. And man, did I learn about scale. Like, I mean, we had, at the time I left, 50 billion impressions of our YouTube information page on COVID. And I believe it's now at 80 billion, but when I was there, it was 50 billion. So talk about back to my patients, getting information to people in a way they understand. Like that's the core of Google, is taking information in COVID particularly and making sense of it for local, regional, where do I get the vaccine? Is it safe to go out? Am I supposed to eat the vegetables or wash them? I can think of all those questions we had. And Google literally provided those answers to the world. And if you look at Google's trust during COVID, it went up considerably worldwide. No one was Googling, maybe people were Googling how to make sourdough bread, but most of the things that people were Googling were health related. You weren't like making dinner reservations and, cruises and stuff like that. So it was our team really providing that information. You mentioned the project we did with the NHS. That was, again, organizing, in this case, medical information and making it useful. And it's an interesting AI story there. So with NHS, which is an amazing system in the UK that people just love, they have in the hospitals, which they call trusts, these rapid response teams. So like if somebody gets sick in the hospital, the nurse or the doctor goes sees Mrs. Smith in room 2 because she seems to be going the wrong direction. And so normally if these hospitalized patients had acute kidney injury, it was taking this rapid response team about 4 hours to diagnose it. Mm-hmm. We built a pretty cool app, no AI, that just notified them earlier. It was basically if creatinine, which is a measure of kidney function, went the wrong direction, it went up on their phone. And instead of 4 hours, they were now diagnosing acute kidney injury in 14 minutes. Great. Yeah. And they saw a 30% decrease in cardiac arrests, so really improving care, and a 17% decrease in the cost of care. So it was a perfect example of, good UX in healthcare providers makes healthcare better. And then we did the AI. So what we did was then train the computer on 70,000 variables, and 70,000 patients. And each patient had about 600,000 unique variables. So computer is trained on this massive data set. And then we say to the computer, can you now tell us which patient is going to have acute kidney injury? Humans are taking 4 hours. With a good application in their hand, we got it to 14 minutes. The computer, with 90% accuracy, was able to predict who was going to be on dialysis 48 hours before any signs or symptoms. So what was 4 hours, 14 minutes went to -2 days. 90% accuracy. This patient who has no signs or symptoms of kidney failure, has no complaints, the computer says is going to be in kidney failure, and they were right 90% of the time, in the next 2 days. I mean, it's just like mind-blowing, like anticipatory medicine. As a clinician, I think you would make sure they're not on anything nephrotoxic, then make sure they have a lot of water. But like, you don't even know what to do when they tell you this person who's fine is going to be sick. Right. So amazing, but also scary, because we actually did the training data. That was a research project with the VA, and right. The VA happened to be 93% male. Well, we tried the tool in the general population, 50% female, 50% male. And lo and behold, it does not work as well. It actually works pretty poorly. So this AI stuff is so super cool, but we have to be really cautious about what's the training data. And then when we use the tool in the real world, how do we tell clinicians, be careful, this is not been used in this population, or this is actually appropriate, et cetera. So that was, I think, a great learning from that Google NHS experience.
Mm-hmm. Yeah, I mean, they're all elegant examples, but this again, this principle that you bring up of anticipatory medicine, sort of taking precision medicine, sort of that one extra step is it's a fascinating time we're in. I'll just put it that way.
I kind of think I read that we're pretty close to where we could say to a patient, hey, I just printed out your medical record for the next 10 years. Like I literally can tell the story. It's just large language model completion, right?
Right.
And it looks like you're going to have a stroke in 18 months that's going to be incredibly debilitating. And I'm 90% accurate, my guess. Now, is that an opportunity to say to a patient, hey, but if we change this variable, i.e., get your blood pressure under better control by you taking your meds, I think we can change your medical record, and now you're going to be able to dance at your grandkid's, wedding or whatever it is. Like we're really at the point where we can start thinking about what's going to happen, changing those variables and seeing what that happens, based on your cardiac risk factors and your genomics and your social determinants and your electronic health record information. I can kind of write the rest of the story. Kind of scary, but also potentially really exciting.
Yeah. It feeds nicely into that. I mean, because we on some previous shows we touched on the theme of sort of medication adherence as an example, and just
Yeah.
the numbers behind that were just they were so staggering. Just thinking about when someone decides not to take their blood pressure pill, as you were
Yeah.
saying, what that means and where that trickles down. So that's again, it's quite elegant. So you transitioned from Google Health to Cerner, a major sort of health informatics provider. It happens October 1st of 2021. Less than 2 months later, I guess there's a phone call from Oracle saying, "Hey, we want to write you this $28 billion check and acquire your company," which then closes. I guess most people listening would probably be familiar with Oracle and Larry Ellison and sort of the history of that organization. But say a couple words about, I guess, your brief time at Cerner before it became Oracle, and a little bit of why Oracle decided to get into this particular business.
Yeah, so your date's almost perfect. So I did go to Oracle October 1. It wasn't 2 weeks. I think it was 8 days later, and it wasn't a phone call, it was a letter. So like literally a week after I get there, there's this letter, Oracle wants to do something strategic with us. And I had asked the board when I was getting recruited to Cerner, are you guys selling? And of course, if you're a company, you're always for sale. And they were very open and honest that they had gone through a process previously, but no, they're going to go at it alone. And so I would not have gone had I known this was going to happen. And I don't think I was tricked at all. I really think it came brand new after I got there. And to me, so Cerner is a Fortune 500 company. When I get there, we're the biggest EHR company in the world by far, so much bigger than others. And what I say to the team is, well, that means we got more grandma's blood sugar than anyone else. So now how do we treat that the right way? First, we got to keep it secure, then we got to get it to the right person. Then we also have to think about grandma's blood sugar, about like, does she have ulcers on her feet? And do we need to look in her eyes? And is there good food in her cupboards, right? And so this kind of whole concept of this, the biggest health app in the world, because we got all this medical information and we need to fix the EHR because ours and all the others were never, ever designed for that end user. They were really designed for billing and coding and collecting data for administrative tools as opposed to actually improving care. But hey, we digitized the record. Now let's see if we can do something with it. So then Oracle reaches out, and the background on Oracle is pretty fascinating. So during COVID, I learned this all after getting to Oracle, but during COVID, so before the Cerner acquisition, Oracle said to the US, we'll do the surveillance. They're really a leader in pharmacovigilance on the COVID vaccines,
Right.
and set up that and donated it to the government. And if you remember, during COVID, they said, if you're pregnant, don't take the vaccine. And then a period of time later, they said, oh, we've shown that it's safe for pregnant women. That was actually Oracle. So they said, don't take the vaccine. And then, of course, a lot of people who are pregnant don't know they're actually pregnant. They took the vaccine and it was safe. And then that data was released. And I think that gave Oracle, and Larry Ellison has always had a commitment and a big interest in healthcare, the idea about, okay, let's go for it with Cerner. So yes, they did buy us for almost $30 billion. And it took about a year to get through. And now I've been at Oracle for 2 years. And to be quite honest, in the beginning, I thought, oh my God, here goes another tech company. They never quite get healthcare. They kind of think us healthcare guys are stupid. And it's been the opposite. I think if you look at the graveyard of tech companies trying to get in healthcare, the mistakes are twofold. One, they come in with point solutions, and they're phenomenal, but they just don't work in the ecosystem. And the second, there's lack of humility. There's a sense that, hey, we've done this in banking, we've done this in retail. If you stupid people in healthcare would just use this app, everything would get better. And Oracle's done the exact opposite. So we've not only seen an amazing acceleration in fixing that core EHR. You can now see a patient and never touch the computer. Like, blows me away what we've just released around the core piece. But we've also gone for a whole platform. So instead of just EHR, it's all the things that Oracle's good at, pre-Cerner, like cloud, ERP around budgeting, human capital management, supply chain, claims processing, clinical trials, that pharmacovigilance around the COVID, the whole piece. And the humility is so whole platform. And the humility is we're not doing this alone. We're going to be open and connected. We want partners in the ecosystem to build on us. We don't think that it's all going to come just from Oracle. So it's been amazing. And I'm really, really excited about how fast it's going and the response we're getting. And I think it means we're going to be able to explain healthcare to people in a way they understand and get people in quicker. Like, I mean, it's still driving those same kind of things that are always burning inside of me.
Yeah, let's talk, David, about some of these tools, because each one's a little cooler than the next, but I thought I'd just pull a few out. One, obviously I know you talked about recently at the Oracle Clinical Digital Assistant, and here, once again, going back to this theme of Oracle Health, it's not just about the patient caregiver experience, because we want both sides. We want the patient to be happy. We want the clinician not to be burnt out. We want them to like their patient and so forth. And in this particular tool, it seems like, I guess some of the things that we don't normally think about in terms of, hey, just give me this patient's history and I know what's going on and I don't have to read through however long this takes me. That leads to a lot of things like burnout. At the same time, that patient doesn't want to, had the experience with my wife when she was delivering in the hospital. 20 people asked her, why are you in the hospital? I'm pregnant, but anyway, talk a little bit about this tool, because I think it sort of takes sort of the AI, as you were just mentioning. No, it's not just another AI tool, but really integrated in thinking about sort of the whole patient caregiver interaction.
Yeah, so that's exactly what we're going after. We renamed it the Clinical AI Agent. But what it is from a clinical standpoint, let's talk about the doc, then we'll talk about the patient side, and we'll also talk about like the person at the front desk. But from the doctor side, like if you're a busy hospitalist and you work 7 days on, 7 days off, and starting tonight, you start at 7 at night and you're working a night shift. You show up and there's 40 patients under your care, and you don't really know them. They all got admitted in the last 7 days. And the nurse says to you, the patient in bed 2 in the ICU has abnormal rectal bleeding. Can you go see them? And at the same time, the emergency room calls you and says, we have 3 admissions and we're really backed up. Can you come down right now? Right? This is real life for docs. And so you got 2 basically options. You could go see that patient in the ICU. And we have solved interoperability. We could give you all the records, but it's PDFs and OCR, and you'd have to go through duplicate records. If you really wanted to understand that patient that had that new onset bleeding and do the right thing, it would probably take you 3 or 4 hours. Well, there is no way you have 3 or 4 hours, because they've now paged you again to get down to the emergency room. Right. So what happens today is you're like, well, I don't have enough time to really understand this patient. I'm just going to order everything on this person, even though I probably know it's been done, but I don't have time to go look for it. So let's do everything. I'm going to get a CAT scan of everything. I'm going to call 100 consultants. Let's do a full court press because I don't know how to be more strategic. And then you go to the ER, or you spend 3 hours and then you get fired because the ER says this guy never comes down and sees his patients, right? So enter the clinical AI agent, and a few things happen. You go, hey, Oracle, tell me about this patient, or this could be in an outpatient setting. Tell me about my patient. And using AI, it takes all of the electronic health records from multiple places through HIE, plus information on social determinants of health, about 2,000 different feeds, and gives you one paragraph summary, basically what a good med student or resident would do for you. So this patient is, and then they say 4 or 5 things that are really, really important to know. Okay, great. Now I go see the patient, and with the patient's permission, I say, hey, can we record this visit? They say, sure, and it's just on my cell phone. And I start examining and talking to the patient and listening to their lungs and doing my regular stuff. But, so that ambient listening's going on. But I got a few questions. Like, pretend let's shift to an outpatient, and I can't remember when I changed the metformin, what happened to the hemoglobin A1C last year. Hey, Oracle, can you show me the different hemoglobin A1Cs as they correspond with the metformin dose changing? Just talk to the thing, right? And while the ambient listening is taking place, all of that information is presented to you. So the inquiry gets done, which doctors spend hours doing. Now you just use your voice. Okay, now I'm done with the visit, that inpatient or that outpatient, and there's a bunch of things that need to be done. Labs, specialists, a note, billing, coding, all of those things get done automatically for me. Just human in the loop. Yes, I do want that prescription change. Yes, I do want the note to go like that. Yeah, yes, that is the right order. Yes, that is the right bill. So now I've seen that outpatient or that inpatient, and it literally has done all the hard work for me. It did the summary, it did the listening and the writing of the note. I was able to inquire, and all my actions were done. So now I get down to the ER and can continue with my work. We've now launched this, and doctors are saying it is life-changing. Like, I had lunch 3 times this week and haven't had lunch in 6 years. Like, no more pajama time. I treat a lot of doctors that are retired, and I showed them what this was, and they said to me, I wouldn't have retired. Like, it's that good. So that's one piece. But back to your point about your wife, it's got to be the same on the other side. So, for example, we've all had that text. You have an appointment next Wednesday at 3 o'clock. Press 1 for yes, 2 for no, and don't write anything else because no one's monitoring this text. And we said, no, forget that. So you have an appointment Wednesday at 1 o'clock, and you can write anything you want back. So the note comes back from that patient saying, I've had some abnormal kind of headaches, in pain that are different. I need 2 medications refilled, and I have some questions. I'm kind of not sure I want to get all my vaccines anymore, right? All kinds of stuff comes back from, hey, you have an appointment at 1 o'clock. Right. Then we show how these agents, these AI agents, handle all of that. So one was, hey, there's something needs to be discussed around vaccines. Is there flexibility to add 10 minutes to this appointment? Yeah, there is, because of our tool. Automatically adds it. The 2 refills, one's for the doctor that you're seeing, but one for another doctor, how that gets routed to that person. And then in our demo, that doctor's on vacation and the doctor covering gets it, and how you give them that information in a contextual way. This patient's looking for a refill. Here's the background. We recommend you do it. Click here, and we know they use CVS or whatever, right? So all of the pieces get done for the patient. And then when they show up to clinic, the same tool, it's actually the same data, but the person in the front desk says, we've been expecting you. I know why you're coming in. Actually, there were 3 forms you needed to do. I see you've completed 2 of them. There's 1 more we need. Would you like me to text it to you? Would you like to use the iPad, or would you like it on paper? And then as you go through clinic, we see on the screen of that person in the front desk, they see you're in the back office. They see you're in the exam room. They know when you come out what you need next. All of this connected and keeps working. And when you just take a deep breath, there's a couple things that happen. It's just regular tech that's used in the rest of our lives that has never made it to healthcare. It's like, oh yeah, that's how everything works. And now you just got to focus on the real stuff. Like, should we do surgery for your prostate, or should we wait? But the rest of the craziness around coding and billing and scheduling and all, leave all that to us. We'll take care of that in the background. So it's, and the same tool for the nurse in the inpatient setting where nurses spend 50% of the time at the terminal. Now they can spend time with the patient. And this nurse maybe got certified in chemo 2 years ago, but it's never given one. Well, our human capital management system is connected to the EHR, so you got just-in-time training right in the EHR. So it's basically this platform that connects this crazy system we call healthcare.
No, it's fascinating. And I wanted to ask one about, because you mentioned along the way there sort of the social determinants stuff, and the because you have a tool called the Oracle Health Determinants of Health solution that takes into account, and you were mentioning your wife's work with the fresh food pharmacy, and so right, it's not just diagnosis, treatment, and vaccination, but hey, we might have a food desert over here, and if there's not enough, fresh fruits and vegetables in this neighborhood, which does better than metformin, then we should do X. Or if the air quality is bad, and how do you tap into all that data? I mean, because I see, like, I guess supermarkets and weather centers, and I mean, it seems like, yeah, obviously it's all about health, and as you point out specifically on this product, hey, health is much more. It's this whole person concept. How does any interesting examples of sort of integrating some of these non-healthcare players in the social determinants package or the solution that you provide there?
Yeah, so those examples that you gave around air quality and food deserts, et cetera, all that information is actually publicly available. So our POP Health tool, Health Data Intelligence, captures 2,000 sources of that kind of publicly available data. And it's actually built in an EHR agnostic way, but if you were using it with our electronic health record, then it's actually integrated right in. So a few things. One, the doctor seeing the patient would be in that summary before, hey, tell me about my next patient, would see this patient has a high likelihood of food insecurity, because we captured that from outside the electronic health record. Now, when you actually talk about burnout, it wasn't that docs were burned out using the EHR. It was docs were burned out because, like, a substance abuse person came in with an infected heart valve from IV drug abuse, and you would give them antibiotics, and 3 weeks later they'd go home, and then 2 weeks later they're back with an infected heart valve, right? It was like, I can't get them the real treatment they need out there other than keep, revolving door fixing their heart valve. That's what drove burnout. So when you actually think about this person coming in with potentially domestic abuse or food insecurity or transportation issues, those things the docs will avoid asking about if they don't have something to do for you at the end. It's like, I don't even want to open that can of worms. So it's a combo of bringing in the data, but then making it very easy to get that person enrolled in that food prescription program. Like, so that's one of those actions. So that's from a patient standpoint.
Right.
But if I'm running a health system or a case manager or a minister of health for a country, I may want to know overall, are we doing enough mammography? How's my colonoscopy? Should I do a campaign around colon cancer, right? We've seen an increased risk. Same thing, that health data intelligence, you literally can just talk to it. Hey, I think I need to do a mammography screening campaign. What should I do? Literally, you talk to the system and it says, well, here's your rates of mammography. Here's how much it would cost. Here's the follow through about, do you have enough places for people that are caught? Would they be seen? Do you need to build your breast center? Like, it does the whole thing for you at a pop health level. So whoever's looking for help around information, we provide it in a way that's contextual for you, but it is the same data. It's just parsed in different ways.
Got it. Got it. No, I didn't know it was that available, but the fact that you have the capability to grab it all, and no, that's awesome. And that's really another awesome example where these tools are headed. So I appreciate that. One other area I wanted to ask you about, because I think it was at the end of 2018 or so, we went through this threshold where older people over 64 years of age for the first time ever surpassed younger population of sort of under the age of 5, I believe it was, and obviously this major demographic shift, social, economic, obviously health consequences. The theme of aging, and specifically aging in place, has been very hot for us. And I know you were interviewed about this a little while ago, not just, the principle of sort of the consumer experience and, health in the home, but some of the mental health applications, loneliness, social isolation. These have been, targeted lately as being as, important as blood pressure control and stopping smoking and all that. Can you say a few words just about the theme of how Oracle looks at this principle of beyond the hospital and aging in place?
Sure. So I'm going to exaggerate, but my sense, but that doesn't stop me. My sense is that by and large, most inpatient hospitalizations are failures of outpatient care.
Okay.
Right. And outpatient care, again, exaggerating, is usually a failure of home or self-care. And self-care or home care is usually a failure of not loving your community. So I know I'm exaggerating, but if we really loved our community, we'd have to take care of ourselves less. We would certainly not go to the doctor as much, and we wouldn't ever end up in the hospital, right? So as we push toward community, loving your community, it's pretty clear we should be able to look at communities and say, what do they need to keep them healthy? And when you look at a community with folks that are seniors, it's really clear that it's, obviously these chronic conditions that we should have caught earlier or hopefully can change the trajectory of heart disease, cancer, obesity, mental health. But the real drivers are, sense of purpose, connection to the community. There's these blue zones, whether you believe in them or not. But when you kind of boil it down, it's like it's kind of the stuff our moms all told us to do. Eat good food, have some friends, move more, and love one another. Like, I mean, it's pretty straightforward. And so we think that data can play an incredible role in allowing us to go in that direction. And Oracle Health is global, and when we go outside the U.S., this is, I mean, if you're the minister of health for whatever country, Sweden or something, or in the Middle East or Australia, anything that improves quality and decreases cost, you want to do. And the biggest drivers are these social drivers around, well, we're launching in Sweden, and they are using an old EHR of ours and moving to a more commercial grade one. And one of the things they've been upset with, and I think we fixed it, is they like to prescribe opera. And our system doesn't do that, our new one. Now I think we fixed it. But when you think about it, that's like, wow. I mean, talk about a social intervention that, this may really help this senior feel connected, if they, it could be anyone, but pretend it's a senior, that, to go to the opera. So these kinds of social interventions, you see happening much more broadly when the provision of care and the payment of care is pulled together in places outside the U.S. And then there's a few places in the U.S. that, we always go back to these same models of Kaiser, Geisinger, Intermountain, whatever, where we've made the step of combining those things. So again, this kind of big data to be able to understand, hey, was actually the opera effective or whatever it is, could be really, really helpful.
I'm a pharmacist by undergraduate training. I would love to see an opera prescription.
There you go.
Hey, what are you gonna do? Um, Dude, I want to come now full circle if we could. And, we started off our discussion with pediatric psychiatry. And again, I was reading an interview that you gave just a couple months ago. And you were asked sort of your thoughts on digital innovation and sort of this burgeoning youth mental health crisis that we have upon us. Everyone needs to figure out, is this tech good? Is it bad? On one hand, I see my kids getting those little dopamine pings throughout the day. At the same time, FDA is approving, digital health tools and games for ADHD at the same time. again, I don't have a core question here, but love to have your thoughts on sort of where we're headed in 2025 with these tools. Are they good? Are they bad? What's the David Feinberg perspective on where
Yeah,
we're headed with all this? Because we got an issue on our hands here.
it's especially with mental health where access is so hard. Back to that, you had to know someone to get in to see me. Um, can we think in a safe way about how to scale care using these digital tools? And in pediatric mental health in general, there's now some pretty good evidence treatments that translate well into a digital platform, basically cognitive behavioral therapy, like as an
Right.
example. So cognitive behavioral therapy does really well. The other thing is that this is a hard one for docs, but patients are more open and honest about suicidality to a computer than to a human.
Mm.
So not only can these tools, help scale treatments, in some ways, they actually may be better than human interactions. All that being said, I wish your kids were less on their phones
Me too.
and more interacting and more active. And there's all kinds of risks to, um, non-human attachments. But hey, who am I to say? I think that train's left the station, and so what can we do to make sure we get more good than bad? But the actual digital interventions, I think, can be very, very helpful, especially in areas that are underserved, that there isn't anyone out there to treat people. The other thing these digital interventions, I think, can be very helpful for is they can up level other providers. So like we did this at Google, a good computer vision on skin disorders can make a nurse practitioner as good as a
Right.
primary care doc, and a primary care doc as good, in most cases, as a dermatologist. Well, everyone would like to see a dermatologist, but if there isn't one and the wait list 6 months, well, this is actually a nice way to scale those things. So that's how I think about it. Can it help bring folks up? And in some cases, it may, jury's still out, be actually better than human intervention.
Hmm. Fascinating. Really fascinating. Um, David, what's coming up for 2025 that we should know about for Oracle Health? Um, Anything that specific topics or products that I missed, or public facing stuff that we should be on the lookout from the organization as we get into the new year. And anything else you want to talk about, please?
Sure. So for 2025, here's what we need to do at Oracle Health. We need to deploy and implement these new tools. Now we've gone to general availability, so this is no more talking about it. We built it,
Right.
and there's small number of people, thousands of doctors instead of millions, using it. 2025 is about scaling it. And when you scale it and you go from those early adopters to others, you learn so much, right? So it's a year for us to kind of prove it and also make sure we stay humble and understand, are we really helping workflow, or what's happening with these deployments that could be causing it to not go well, right? So it's that back and forth that's happening this year, and it's at scale. We're talking about US and outside the US. This is a big, big year for us to do it. The other exciting pieces, I'd say they're a little more on the periphery, although I think we will see real acceleration in 2025, is like claims processing and prior authorization, and that whole kind of ecosystem of noise and garbage. We're really digging into that, and I think we'll be able to start showing folks, hey, we can help that end to end, regardless of what side you're on, the patient, the provider, or the insurer. We can help make that piece go. And then the same, again, just starting to dig into it deeply around life sciences, where Oracle has had software for you to get your study design and works with big pharma.
Right.
Cerner came to the picture with real world evidence, pulling that together so that we're not just going bench to bedside, but that we go bedside back to bench, that the real world evidence is actually driving some of the clinical discovery. So, scale out the core EHR, that pop health tool, and then on those adjacencies, but absolutely crucial, the claims adjudication engines and the life sciences.
Yeah, but I'm glad you threw that piece in there about the distributed clinical trial. It's something we don't touch on as much, but it's here.
Right.
And the fact that clinical development and some innovation, these new pharmacotherapeutic products are beyond where we've been in the past with how we've done that in big pharma. So no, it's exciting. I'm excited for you. It's an awesome organization, and again, I really appreciate the time taking us through not just your career, but ultimately where all this is headed. And again, it's nice to see it not just being implemented, but scalable, because that's what we have to be scalable when we talk about these population health issues. So really, really awesome work, David. Again, for everybody that's going to be listening to this particular episode of our show across the various podcast networks, or who's watching on the YouTube channel, again, you've been spending time with Dr. David Feinberg, Chairman, Oracle Health, doing really amazing things to improve the patient and caregiver experience, and ultimately, as they say, make healthcare more accessible, affordable, and equitable. David, again, I want to thank you for taking the time out of your schedule to talk to us for a little while. Thanks for everything you're doing. And as we like to say on our show here, thanks for creating a better tomorrow for many people out there. Really, really an awesome story.
Well, right back at you. Real pleasure. And thank you for getting the word out.
Great having you.